lot of trainees in general surgery end up pursuing any combination of acute care surgery or trauma or intensive care practices. So it's important to provide an overview of that as well. And so our next speaker will be representing the American Association of Surgery or Trauma, Dr. Scalea. He's a professor of surgery as well as the physician chief of Shock Trauma Center in Baltimore, Maryland. Please, Dr. Scalea.
Acute care surgery, kind of the new kid on the block. It came out of several needs. 1,000 years ago, when I was in New York City in the middle of the crack wars, we operated 7 days a week, 24 hours a day on penetrating trauma. That was the disease. Catheter therapy and non-operative management replaced many operative procedures. Critical care fellowships fell in popularity because there wasn't that much surgery. And over a series of years, as all of the other speakers who have preceded me defined their specialties, there was a need for people that wanted to take care of kind of all the other stuff, the stuff that I was trained in. I was a general surgeon. I'm still a general surgeon. Call me, I'll fix your problem. And that has become the specialty of acute care surgery. I was on call yesterday. We admitted a young man about, I don't know, the only thing that was unusual was that it was during the day. He had 12 holes in him. And in 3 hours, I did a lung resection, fixed his heart, did an extraperitoneal approach to his iliac artery, and repaired that. That's what we do for a living. It is a broad-based practice in a huge number of disease states, and we want to take care of everything. We don't want to be a coned down specialty. What's it mean to do this? You get a huge operative experience depending on where you go. And since you have to do the critical care year first, it's a nice way to return to a largely operative practice. As you know, the Critical Care Fellowship is 9 months in the ICU. This allows reintegration, if you will, into the operating room. This is geared towards complex general surgery. This is not supposed to be your average lap chole. This is the lap chole in the patient with septic shock and multiple organ failure. That's what we do. And we place emphasis on operative exposure as well as just getting the procedures done. We are in the middle of a discussion with the Pan American Trauma Society, and I think very likely we will soon be offering opportunities to go to other countries. We've had several of the fellows go to Cali, Colombia, where they did over 100 operative cases in 2 weeks, mostly geared towards penetrating trauma. So it's a busy operative practice. We now have a case log to measure this. There's an exam at the end of the year, and the certificate's via the AAST. It's a little schizoid because the Critical Care Fellowship is ACGME approved. The acute care surgery year is AAST approved. There are currently 18 approved acute care surgery fellowships, many more critical care fellowships. We've finished about 60 fellows. You can see most of them are practicing acute care surgery. Most are working in relatively large urban or suburban places, and most of them are pretty happy. Now, what does it mean? It means a lot of different things depending on where it is you work. If you work for me, this is a heavily trauma-based. We do 2,500 general surgery trauma operations a year. We do about another 1,000 acute care surgery. If you go to Pittsburgh with Andy Peitzman's group, it's the flip. It's about 1,000 operative trauma cases. It's 2,500 or 3,000 emergency general surgery operations. And so it's very variable. If you go to many places, general surgery and trauma care is lumped together. So when you're on call, you cover both. We're way too busy doing trauma. So we have two separate people. We have two people on call each night, one covering general surgery, one covering trauma. And all of us have created some mix of general surgery, critical care, trauma, and virtually all of us have relatively large elective referral practices for a multitude of general surgery kinds of things. Everybody now matches as a single match. So if you want to come do our acute care surgery fellowship, you match into our critical care program and our acute care surgery program in a single match. I fought that and I gave up this year. You need to apply by kind of the middle of your fourth year. Interviews start around June. We match in the fall, and match day or the results are usually on Halloween, which is its own story. Now, you can do 1 year, you can do the critical care year, or you can do the 2 years. You can't do the acute care surgery year without doing the critical care year. My personal observation is that the 2-year fellowships are now far more competitive than the 1-year fellowships. You'll go back a few years, there were about 70 kids that applied for 200 jobs. Last year, 3 years later, it was about 130 kids that applied for 200 jobs. And this year, it looks like it's going to be more. So each year, it has gotten more competitive. And I think the addition of the acute care surgery year has really juggled that. So we now have many more kids that want to do the 2-year fellowship. And so when we do the match list, you end up juggling the numbers because it's 2 separate matches. Residency location and reputation count. You may be a wonderful person, but if you've trained at a very small community general surgery program, there's no way you can come be my fellow. You just don't know enough on the 1st of July to be able to do that. That's different depending on where the fellowships are, but the AAST approved acute care surgery fellowships are all at all are very large academic places, and so that kind of changes the flavor. There is some variability. This is the operative curriculum. We're sort of in the middle of the final revisions, and what we're doing is setting up the minimum numbers. This is the chest you can see, and there's the organ management numbers: 35 lungs, 5 diaphragms, 5 hearts, 2 esophagus cases, 3 great vessel cases, and then we break it down into the specifics of the organ management and have decided that simulation can count for some. This is just my fellowship or our fellowship. Our fellow, the acute care surgery fellow, does about 330 or 350 cases in the single acute care surgery year. It's a lot of surgery. And even our fellows do about 150 cases in the 3 months that they're doing the trauma side during the critical care side. So you end up doing about 500 cases in 2 years. After you get done with the fellowship, what do? Well, it's real easy to get a job. Now, I always remind the kids that come to look, it's easy to get a fellowship job. It's just hard to get a great fellowship job. There are lots of fellowships. There are about 6 or 10 great fellowships, and those are highly, highly, highly competitive. Same thing kind of true. Everybody's looking for people, but the rules vary considerably from hospital. One of my former fellows called me after he took a job I told him not to take, and he said, I went there and they told me that I'm not allowed to do colon surgery because I have to call the colorectal guys for this. I'm okay to divert the patient, but when it's time to close the colostomy, I have to call the colorectal guys. And I said, were you listening when I told you not to take that job? And so it's important as you look for a job to understand what the particular profile of what the acute care surgery service is doing, or you go someplace and you find out that you can't do what you thought you were going to be able to do. But I look to as acute care surgery being really something that's going to continue to morph, and there are going to be a lot of jobs. And I think it's a great way to spend some time.